Atrial fibrillation is the commonest sustained arrhythmia that we identify in primary and secondary care in the Western world. We know that as soon as someone develops atrial fibrillation, the risk of stroke goes up 5-fold, and that they also have a risk of developing heart failure if their heart rate is particularly high. So it's very important to identify atrial fibrillation and manage it to prevent stroke and to prevent heart failure. So again, we come back to making every contact count. So patients who come to our long-term conditions clinics with heart failure, hypertension, CKD, existing cardiovascular disease, previous stroke, diabetes, are all at an increased risk of developing atrial fibrillation. So we should be checking the pulse in all of those patients when they come to our long-term conditions clinics. If it's irregular, we should then be doing an ECG to pick up atrial fibrillation. Once atrial fibrillation has been detected, we then need to do a stroke risk assessment using the CHADS2 VASC tool, and also assess bleeding risk using Orbit as advised by NICE. Patients should then be offered a direct oral anticoagulant in preference to warfarin, as is outlined in the NICE guidelines, if they are at an increased risk of developing stroke. The DOAC to be used will be determined by the clinician based on that patient. It's then important that patients are monitored, because we do see a lot of inappropriate dosing of DOACs, and we should be using tools which are available in CDRC and other tools that we have to be able to identify those patients who are on an incorrect dose of DOAC and adjusting that, because if the DOAC dose is too low, they're at an increased risk of stroke. If it's too high, they're at an increased risk of bleeding. So I do think we need to focus on predicting whether patients have AF in long-term conditions clinics, detecting, protecting by using a DOAC, and then perfecting the dose of the DOAC. If they happen to be on warfarin, because they've got a mechanical heart valve or moderate to severe mitral stenosis, we should also be looking to achieve a good time in therapeutic range of over 65%, as is outlined in NICE guidelines, to optimize the reduced stroke risk. There are resources available to help primary care. In the Northeast and North Cumbria, we have the AF card deck, which can be downloaded from the AHSN website. And the Primary Care Cardiovascular Society is a national community interest company that is free to join for any healthcare professional. And on that, there are a lot of resources for atrial fibrillation, lipids, hypertension, heart failure, and any CVD area that you wish to learn more about.